may I now request Dr. Subhasree? She is going to discuss about one of the important complications of cataract surgery, that is cystoid macular edema.
Thank you so much, sir. So my topic today is pseudophakic cystoid macular edema. Before beginning, slide, change. Yeah, thanks. So before beginning, we must thank these two distinguished doctors, Dr. Ray Irwin, who actually reported the syndrome first, and Dr. Donald Gass, who later elucidated it with a fluorescent angiogram. So the risk factors, we all know it involves a posterior capsular rent, surgical complications involving vitreous loss, any sort of iris injury, iris manipulation, dislocation of intraocular lens. The patient who has a previous history of some diabetic macular edema or uveitis can happen after an uneventful cataract surgery also. So the treatment involves corticosteroids and NSAIDs. Corticosteroids can be given topically, periocular injections, and intravitreally. So this is my first case scenario where this patient was presented with the above OCT, as you can see, and we started him on topical corticosteroids and we monitored him every 2 weeks to see the response, and he was actually showing a good response along with some topical NSAIDs also, and it completely resolved on 8 weeks. In refractory CME, we have the options of posterior subtenon injections, intravitreal injection of dexamethasone implant, as well as triamcinolone acetonide. So this is a video showing the PSTA injection being given in our institute. So this is my second case scenario with this is the right eye of the patient, and before cataract surgery we can see all is good except some perifoveal thickening of the retina. Following the surgery, at 1 month follow-up, he presents with a cystoid macular edema. He was given a posterior subtenon triamcinolone acetonide. And at 3 months follow-up, he still had some CME and was given a second injection of PSTA. So at 5 months follow-up, he received an IVTA. His best corrected vision was 612 at that time. And he was maintaining a good foveal contour with a good vision at 6 months also following the IVTA. And then he came back 3 years later with again a cystoid macular edema and was given intravitreal dexamethasone implant. And 3 months after the dex was given, he developed an epiretinal membrane. So this is the right eye of the patient, as you can see. So while operating his left eye, we were cautious and we gave a prophylactic PSTA injection along with the phacoemulsification surgery. And till 1 year follow-up, he was doing very well. He came back 2 years later with a CME and his vision dropped to 612. And he was given an intravitreal injection of dexamethasone implant. And 3 months after that, he came back with epiretinal membrane and a pseudohole. His best corrected vision was 612 at that time, and since then he has been maintaining this. So this is another peculiar case we have reported. We noticed this patient showed a bilateral effect following a unilateral injection of intravitreal brolucizumab. So this patient had a pseudophakic CME 3 months after the surgery and was on topical therapy, following which he received intravitreal Ozurdex, he received IVTA, and then he received brolucizumab in the right eye following 1 month follow-up. As you can see in the last OCT, there was response in both the eyes. And the most peculiar thing is that he received the injection in the right eye and his response was more in the left eye. The surgical treatment options include the laser vitreolysis, pars plana vitrectomy when CME is complicated by some vitreoretinal traction. So this is my third case scenario where there is a patient, he had an intraoperative PC rent with some vitreous loss, and there was some chronic CME with vitreous in AC. The lens was also decentered. So we decided to proceed with anterior vitrectomy and with some IOL repositioning, redialing, and an injection IVTA. So this is a small video of the surgery. This patient showed a good response and had a complete resolution of the CME, as you can see in the OCT. So how CME is managed in our institute? We initially begin with a tapering dose of topical steroid prednisolone over 6 weeks along with topical NSAIDs. We follow up the patient every 2 weeks and we see the response. Only if the patient is responding, then only we continue with the topical tapering dose. Following which, if the patient is non-responding, we have the options of posterior subtenon injection of triamcinolone acetonide. Some intravitreal triamcinolone acetonide or dexamethasone implant can also be given in non-responsive or refractory cases. We have intravitreal injection of anti-VEGF also. And we go for vitrectomy if any complication is present that needs any surgical intervention. So for prophylaxis, we can say that we have to manage any pre-existing ocular conditions, any inflammations like uveitis should be managed before the surgery. And this is one question. This question was actually asked by my sir, and I replied in a very obvious manner, like, what do you see here? So even I want to ask the audience this question. Like, this is a pseudophakic patient, has a best corrected vision of 618, presenting to you with 3 months after the phacoemulsification surgery with this type of OCT. So what will you see? This is also a non-diabetic patient and how to treat. So I was very happy and I responded with, this is CME, sir, so I'll treat this patient accordingly. But no, we have to see all the sections of the OCT. So this is what the other sections showed and this is what he had. So please don't jump to conclusions and see all the sections of OCT. Thank you so much for your patience.